I'll just quickly take you all through Press Beyond laser blended vision. So it's going to be more of a theoretical talk because Press Beyond is essentially a form of LASIK. Only difference is you treat both presbyopia and emmetropia as well. So just to be clear, so it's an excimer laser-based corneal refractive surgery for the treatment of myopia, hyperopia, along with presbyopia also. So what we do here is in the patient's eye, the dominant eye, we will target for planar refraction, whereas in the non-dominant eye, we'll target for minus 1.5 for near vision. But the catch is this is not just monovision, it's a blended vision. So a lot of people get confused. They look at this and they just say it's monovision. But the idea here is Presbyon will extend the depth of field in both eyes using spherical aberration. So the dominant eye will also get some amount of near vision, even though it's only supposed to be for distance. And the non-dominant eye will get a good amount of distance vision, even though it's only supposed to be targeted for near. That's why Presbyon is different from normal monovision. So rather than saying it's monovision, you can say that yes, it uses the concept of monovision, but improves on all of the disadvantages by extending the depth of field by controlling a therapeutic amount of spherical aberration. So rather than calling it as a monovision, it's called as a blended vision treatment. So what exactly is spherical aberration? So this is an aberration that we are used to living with in a daily basis. So our lenses by nature are spherically aberrated, and as we keep aging, the spherical aberration keeps increasing. And also when we accommodate, when we look at something for near, the lens gets more spherical, and by nature we have more spherical aberration, and that gives us better near vision. So this is an example of spherical aberration. As you can see, this is a spherical lens where the peripheral rays are focused in front of the central rays. So that distance between the peripheral rays and the central rays gives rise to a circle of least confusion, like you see in a conoid of Sturm. So that circle of least confusion, whatever is in focus in this circle, will be in the patient's depth of field in that view. So this is what Presbyon does. It induces a mild amount of spherical aberration to increase depth of field for the patient. But there is a therapeutic amount. You can't just increase spherical aberration and just keep thinking it's going to give you more depth of field. Beyond a point, it will reduce image quality. So the ideal amount of spherical aberration we need is somewhere between 0.3 to 0.5. So that's what we target when we do Presbyon. So let's just look at a working concept of Presbyon. So let's say the dominant eye, we've done Presbyon and the patient is now reading 6.5. But because the spherical aberration is induced for this patient, the near vision in the dominant eye itself will come to innate, which is excellent. So the dominant eye itself has innate vision. The non-dominant eye, which is targeted for minus 1.5, has a near vision of N5. But even with this 1.5, the patient is able to read up to 6.9. So typically with the minus 1.5, the patient could only read about 6.18 or 6.12, right? But because of the presbyon profile and spherical aberration, even the near eye has good distance vision. So when the patient is blending together, their vision is amazing. They have 6.5 and 5 both for distance, intermediate and near. The refraction protocol is what is very, very important in Presbyon. There's a very strict protocol to follow, where the patient has to see which the dominant eye is, which the non-dominant eye is. You have to keep pushing for maximum spherical acceptance in plus and maximum cylinder. So we want to get all the cylinder out of there. And we do the Presbyon trial and we see whether they're accepting the plus 1.5 in the non-dominant eye. This is the most important part of Presbyon. So what we did is we did a study where we took a series of eyes which are treated with Presbyon and we saw the refractive outcomes and as well as the eye trace observed depth of field. So what we did is we looked at the eye trace, which is an aberrometer, and the eye trace tells us how much depth of field that the patient's eye actually has. So this is a very objective measurement of the patient's depth of field. So like you see here, this is an example of the eye trace. As you can see in the x-axis, you have the refraction, and you can see this patient is slightly myopic, and the y-axis we have the image quality. So the eye trace gives us a measurement of the image quality in terms of aberrometry. So in this refraction, the patient has 100% image quality. And beyond the 30%, beyond the 30% cutoff is where the image quality is no longer very useful for the patient. This is how we calculate depth of focus. So this patient has a depth of focus of 1.25. So when you do Presbyon, The extended depth of field gives rise to a 1.25 diopters of extended depth of field, and the other eye, which is more myopic at minus 1.5, it blends with the other eye and gives us an effective range of focus almost up to 2 diopters. So the patient ends up having a very good range of focus. So if this is a patient who's just wearing single vision glass, the effective range of focus is about 1.25. When they were wearing a varifocal glass, like a progressive glass, the range of focus is about 3.5. This is what we try to emulate with Presbyon. So what we found in this study is the pre-op period, the depth of field increased in compared to the post-op. So the effective range of focus in all of our patients put together was about anywhere from 2.5 right up to 4 diopters. So that means even a 50-year-old patient after getting Presbyon done has an effective range of focus between 2.5 to 4 diopters, which is amazing. So the outcomes are also very good. This is also a study I did with about 22 hyperopic patients, and I followed them for 6 months. 95% of these patients had 6.6 with N5, and 81% of these patients had 6.5 with N5. This is in hyperopia. Similar results in myopia as well. We found myopic patients 100% had at least 6.6 N6, whereas 60% of patients had 6.5 with N5. And also, as recently in February, I performed Presbyon for my own father as well. He's also an ophthalmologist. His age is 67. He had no cataract. We did the Presbyon on a Monday afternoon, and on Tuesday morning, we saw his vision. He was 6.5 with N5, and the next day morning, he's also operating cataracts. There is no issue at all with blending. There's no issue with depth perception. Very comfortably, just about 18 hours after surgery, he's back to the theater operating his own surgeries with no issues whatsoever. The most encouraging part is when you offer a presbyopic solution instead of a lens exchange solution, patients will be much happier to take it up. Our volumes of presbyopic patients we have treated in the last 1 year has enlarged exponentially. We used to do about maybe before introducing Presbyon, we used to do maybe 3 to 5 clear lens exchanges for presbyopia in a practice every year. But now, as of the last 2 months, we have done 10 Presbyons every month. So it started from 2 to 3 a month, 4 to 5, and then we're slowly coming up to double digits. So patients do want a solution for presbyopia, and they would like it to be a laser and not lens exchange. So this is what we've seen in our practice. So to conclude, it's an excellent option for the correction of presbyopia in the absence of cataract for both myopes and hyperopes. But it's a very intricate solution. You have to be onboarded with the exact standard operating procedure. I would highly recommend that you attend the Presbyon courses by London Vision Clinic before you start to adopt this procedure in your practice. Thank you for your attention.
Thank you very much, Dr.